Hi, good afternoon, everyone. Welcome to all the attendees for this webinar. Good afternoon, everyone. My name is Khushbu Sharma, and on behalf of Voice of Healthcare and Wolters Kluwer, I welcome you all to yet another interesting session of our series, that is CDSS series, Strategic Insights from the Frontliners. This series is brought to you by Wolters Kluwer in association with Voice of Healthcare and is powered by UpToDate. The topic of this episode is, what is the role of CDSS in private hospitals in Tier 2 and Tier 3 cities? Now, allow me to introduce both of our speakers for this discussion. Our guest speaker for this session is Dr. Suresh Vishwanathan. He is the Managing Director at SKS Hospital and Postgraduate Medical Institute. Dr. Suresh finished his MBBS from PSG Institute of Medical Sciences, Coimbatore, and completed his MBA in Healthcare Administration from Cleveland State University, Ohio. He has a special interest in medical informatics and is the Managing Director of 34 years old, 250-bed SKS Hospital and Postgraduate Medical Institute in Salem, Tamil Nadu. The hospital has broad and super specialties under one roof and is a postgraduate training institute affiliated to the National Board of Examinations in Medical Sciences. The hospital also runs a medical college. Welcome, Dr. Suresh. This session will be hosted by Dr. Rakesh Prabhu. He's an MBBS MD in Hospital Administration. Dr. Rakesh is working as a Chief Medical Officer and heading the medical services for Medicover Group of Hospitals, India. He's a medical graduate and worked as a medical administrator previously in premier institutes like AIIMS, Delhi, and Nizam's Institute of Medical Sciences, Hyderabad. I'd now request Dr. Rakesh to take over and start with this interesting discussion. Over to you, Dr. Rakesh.
Thanks for the intro, Khushbu. Good afternoon, all. I welcome you all for the today's webinar, wherein we will be discussing about the role of CDSS, which is Clinical Decision Support Systems, in private hospitals of Tier 2 and Tier 3 cities. And this session will be followed by a question and answer round. So before going any further, let me give a quick brief on importance of CDSS. Healthcare staff nowadays are being confronted by vast amount of clinical data for each patient they treat, which it also associates the exponential increased data of medical research. So while the existing electronic health records and databases are helping physicians manage their rising tide of information, this patient-specific recommendations provided by CDSS can do much more improvement in improving our decision making and helping the patient safety. So to go much deep into the topic, I request Dr. Suresh Vishwanathan to take it over from here and enlighten us with his speech. Over to you, Doctor.
Thank you, Dr. Rakesh Prabhu. And hi, everyone, and thank you for inviting me. So first of all, it's a very nice introduction to CDSS. And ideally, everyone should have access to a CDSS in India. But there are always challenges because there is a cost aspect to it. So one of the challenges for a Tier 2 or Tier 3 city is optimizing cost when it comes to patient delivery. And subscribing to a CDSS does involve a cost. In countries like Europe, especially UK, the government at a country level subscribes to these CDSS platforms, which allows any physician, any practicing doctor to access to it. But in India, we're still largely private healthcare driven, and we would have to add that cost. But hopefully by the end of this talk, most of you realize that the cost is definitely worth it. The other thing is CDSS are fully online-based systems, so you would need a good internet connection, a reasonably good internet connection. And I think in the last 5 years, we have grown leaps and bounds in India when it comes to internet connectivity. So that's no longer a major concern, but it's something that has to be kept in mind if you're are going to increasingly depend on your CDSS for patient treatment. So now if you look at the phrase, the new normal has become popular. After COVID, everyone talks about the new normal. And let me leverage the same phrase. and saying what's the new normal in healthcare delivery. And I would say the new normal is CDSS. Medicine has always been about using the latest tools in your arsenal, be it the medical or surgical field. For example, when laparoscopy was introduced, initially it was an exotic thing. Now everyone, your standard of care for general surgery is laparoscopy first, and then only otherwise you go for open surgery. Or for example, when cath labs came in, cath labs with this expensive equipment that if a patient had a heart attack, you would wait for the patient to recover, and then you would shift them to a hospital that had a cath lab and do interventional angiography. But now, like the standard of care is if patient is having a heart attack, how soon can you get him to the cath lab to do a primary angiogram? Like that, you have new weapons that we use in our portfolio, and CDSS is one of those weapons. So CDSS is a very valuable weapon in your fight against disease, and keeping up to date. Like every doctor knows, from the moment they graduate, they're out of date. They need to keep themselves updated by attending conferences, reading journals, and the new editions of textbooks. Every edition of a textbook becomes bigger and bigger. Every time there's a new edition, the book just becomes bigger, or sometimes gets split into 2 volumes. And it literally is impossible, even within your specialized field. It doesn't matter whether you're, say, a nephrologist or orthopedic surgeon or a general physician, to be able to keep yourself up to date with everything that's happening in this field. The growth in information, medical information, has been just exponential. I graduated about 25 years ago, and compared to that, I look at some of the textbooks the new medical students have, and it's huge, and it's just the amount of information that's available. If you see 50 years ago, amount of information, what was coming new was very less. You would update your guidelines or your treatment modality probably every 5 years. But now it's changing month by month. And if COVID has shown us sometimes rapid advances are possible, what would normally take 10, 15 years to develop a vaccine was done within a year. 6 months, they had a vaccine ready. And we're learning as we're going. Like that, just the investment in time and resources to keep yourself updated with journals is impossible. Whereas with the CDSS, you are getting up-to-date information at your fingertips. So it's definitely worth having a CDSS with you. And if you look at adoption levels, I see a lot of individual practitioners actually subscribing to CDSS, people who are aware of the advantages. But at an institutional level, if you see, especially in smaller cities, not many institutions are going for an institutional subscription. Of course, it all comes down to cost. But when you look at it, just the number of people who will get benefited from using a CDSS campus-wide, it is well worth it. When I say campus-wide, that means you can connect to any PC from your mobile, from your laptop, or if you're on ward rounds on a ward PC. And I'm not just talking about consultants, even your junior doctors, or if you're lucky to have postgraduate students, it allows them to check up what is the latest treatment modality. Middle of the night, something comes up and you want to know what to do. You're a casualty and you get a poisoning case, and it's a rare kind of poison. The CDSS allows you to look it up and see what is the current guidelines. And it is quite up to date. They update it every few months, some of them even every month, that you have the latest information on what's available and what should be used as standard of treatment. So if you're a practitioner and you're not using CDSS, then I feel you're doing a disservice to your patients. That's how important I believe CDS are, and it definitely shows a difference in your patient outcomes. End of the day, all of us want to help patients, see them cured as soon as possible, and send them happily home. And this should be part of your repertoire. So your behavior, I've spoken to some, we have it campus-wide, and talking to my consultants and see how they use it. Like my physician was saying, every time I have a patient, I do a quick read up. There's nice thing about CDS is you can get information as broad or as narrow as you want. So if you don't have time, you can just quickly click on the summary, and tells you the summary and treatment modalities. This is what is the latest summary and the modalities. You can click through and get more information. If you think something doesn't sound right, you can go and look at the evidence. And that brings me into evidence-based medicine. Today, everything is evidence-based medicine. Gone are the days where you went with your gut feeling and said, this is how I've been treating it, or this is how my professor taught me, this is how I'm going to treat this patient. But if you look at evidence-based medicine and research, there are different levels of grading of evidence. And when you have random double blind studies, they are the highest level of evidence-based medicine, whereas going by just experience and practice is at the lowest level. So do doctors use CDSS? It definitely has improved outcomes. It allows us to follow evidence-based medicine. There's a very nice summary in most of these CDSs that gives you something like practice-changing updates, and it also gives you the evidence behind it. So it's like an alert, just like you get an SMS alert or WhatsApp alert. You can just look in that page frequently, I mean, at least once a day or once a week, and it'll tell you in your practice what is updated that should change the way you practice or treat patients. And this is really, really useful. Not only does it tell you like this is a practice changing update, nowhere have we seen this more important than COVID, because at one time it seemed that every week new information was coming, and how much of it was authenticated, and our traditional ways of reading Lancet or one of the Oxford journals, American journals, was bypassed, and suddenly even before it come out on the journal, you were seeing it in the newspaper. All of a sudden, your front page headlines was medical news about this is a study done over there. That is a study done there. And how much of it was empirical, how much was it real? But if you have something like CDSS, you can look at what is the update and what is the evidence behind it, and what is the grade of the evidence. Is it grade 1 or is it grade? I mean, as 1 A, B, C. Let me not go too much in depth there, but between grade 1, 2, 3, you can be more confident versus 4 and 5. The other important things are when you look at patient education. Nowadays, patients are more aware. They all have access to Google. They've already studied up their symptoms and think they have a diagnosis. And when you tell them you've got XY disease, CDSS allows you to also show them images, diagnostic images, drawings, and say this is the disease. Even something simple like a renal stone. You can immediately pull up an image on your CDS and say, see, this is the renal stone, this is where the stone is. And with a section, earlier doctors would have anatomical figures or models on the table. But this allows you to quickly show them, and even some of them have videos and animations which shows what is wrong with that particular patient and how the treatment can help. Then comes the other thing like drug interactions. Lots of new drugs are coming in. So before giving a new medication, you want to make sure that it's safe. Not only is the medication safe, obviously if it's not safe, it wouldn't be available in the market, but is it safe with what other treatment you're giving? Just an example is, for example, you're giving immunoglobulins. So you look up immunoglobulins, it immediately say that if you're giving immunoglobulins, then there is a contraindication on giving any vaccines, but not just any vaccine, live vaccines. What is the duration? What are the exemptions? So these kind of data can be gathered immediately. Typically, a lot of our information comes from the manufacturer, drug manufacturer, where the sales rep comes and tries to promote their medicine. But obviously, they're trying to show their product in the best light, and even they're not medical people. So you want to get proper information on what you're giving. And that's why you have a lot of up-to-date drug information, drug monographs. So these monographs give you a quick, concise reading on what this medication is, what is the dosage, and not just dosage, because each patient is different. So you have adults, pediatrics. One of the nice things about CDS is it allows you to narrow down between adults and pediatrics. And if you're giving a medication, you can also look into say, if I'm giving this medicine, what is the indication or what is the contraindication in a renal patient that's compromised or hepatic compromised patient. So you can titrate your dose accordingly. So all this this is like really, really invaluable that you can know that you're giving the right treatment to the patient and you don't face any side effects later. The other thing is as doctors, we use a lot of calculators. A lot of us chose medicine because we didn't like maths, but unfortunately in medicine, we still have to do a lot of calculations, based on patient's body weight or different things. Even like if you're putting the patient on ventilator, you need to calculate FiO2, oxygen saturation. And all these calculators are available at fingertips, so you can just punch in the information needed. And the calculator, again, is age-specific for different patients. So you can do all these calculations. You want glomerular GFR. glomerular filtration rate, it's there. You want to do what is the FiO2 calculation versus saturation, it's there, like that. So these calculators are oxygenation index in ventilated patients, as I say. These are really, really invaluable and allows you to have a good night as a consultant. You can have a good night's sleep because you know the junior doctor has access to it and can quickly look it up. He doesn't have to call you up and say, what is the dose I have to give? And he's also doing the right thing. He's not, you know, using the wrong calculator. So the other thing is like the web. This is all online based, so all the data is hyperlinked. So you can quickly refer, if there's a link, you can just click on, refer to what else information is available there. And that gives you, like I said, the ability to dig in as deep as you want to, or just superficially get the quick information. You get summary and recommendations on what is the current practice. And the other important thing is algorithms, treatment pathways and algorithms. Earlier, you would like study journals, read journals, and set up your own treatment modalities. So each institution would, if you had the time, develop a different path, algorithm and pathway. But these algorithms are readily available. One click, you can save them, export them as PDF, or even use it in presentations. So pathways are a very crucial part of treatment and one-click access. Then you also get to read up-to-date topics, which in turn generate CME credits. The Indian Medical Association has been, or rather the Medical Council of India has been pushing that all of us have CME credits and are up-to-date. And as far as I know, state medical councils accept international credits. You just have to send them a certificate and then they accept it and give an equivalence. So you can read topics and earn CME credits from this. These are the main advantages. But if you look at challenges in adopting a CDSS and EBM in non-metro areas, like I said right in the beginning, cost is one of the biggest challenges. But hopefully people understand that just like you pay for electricity or internet connection, this is something that should be part of your overheads and accepted. A lot of doctors have grown up, treating patients based on their gut feeling, saying, this is how I've been doing it. So there can be initial resistance to switching over to purely evidence-based medicine treatment. But with a CDSS, you can actually show them the evidence and see that, look, this is how things are being done, and get people to change their behavior and say that, yes, evidence-based medicine works and gut feeling treatment can be wrong. Your gut can be wrong. And when they say gut feeling treatment is like, this is how I've been doing, but this is what I feel is right. And if you look at the grade of evidence, that is at the lowest grade, grade 5. So some of the other things that I should cover probably I'm thinking of is, they also list out trials for each topic. And then these trials also change the way that we treat patients. These trials are updated every month. You can also bookmark important topics so that you have quick access. If you're a specialist that frequently needs to calculate oxygenation index, you can have that bookmarked. So this is where having an institutional subscription is useful, because sometimes I know it happens that you have one subscription that is shared amongst people. But when you share your subscription, everyone's bookmark becomes everyone else's, and soon you get lost in that information deluge. So with institutional subscription, you have an individual login, and whatever you customize, whatever data you studies you highlight is for you, and no one else logging in is going to mess that up. These are some of the things that just off the head I can think of. Rakesh, if you'd like to ask or add some other questions, I can discuss that. Rakesh, you've got to unmute yourself.
Yeah, sorry. Thank you, Dr. Suresh, for such an informative speech. Yes, really enlightened us regarding CDSS and the outline of it. I think there's some question from the audience. Let me see. There's a question from Virat. How the patients has been benefited by the use of this technology?
Okay, like I said, there's definite improved outcomes. It may not be as glamorous as a CT scan or even an ultrasound machine, wherein you do an ultrasound and immediately diagnose and say, because I had this ultrasound, I could diagnose this, or because I had the CT, I could diagnose this. So it's not as glamorous as that. But when you start treating your patients as per the latest guidelines, your outcomes are going to be better, patients benefit, and in the long run, you as an individual or the hospital is going to get word of mouth saying that yes, this patient went there with critical illness and then was treated. And since the topic today is on focusing on tier 2, tier 3 cities, you've got to understand that in a smaller city, we're always in constant competition with the bigger cities. Patients tend to believe that if they go to the metro, they get better treatment, but it's not necessarily always true. Today, we've got specialists and super specialists at even smaller cities, and the facilities are equally good. But trying to get the patient to accept and believe in you, these are some of the outcomes. So when they come here for treatment and then they get better, and over a period of time, this word of mouth helps you. So it definitely helps in outcomes. I see there's one question also, which Dr. Rupali has asked. Is CDSS beneficial in individual doctor practices also? And I would say yes. It's actually much cheaper for an individual doctor to subscribe. And I know friends of mine, classmates who use it, and it definitely is useful at an individual level also.
So you spoke about the new normal during this COVID pandemic time. So, and how do you think that CDSS is enabling to that new normal?
Sorry, could you repeat that again?
So we spoke about the new normal during this COVID
Yeah.
pandemic time, right? So how do you think that the CDSS is enabling to that new normal thing?
No. Okay. CDSS, when you say new normal, is a new standard of behavior. So that's what you
Yes.
say by new normal. So like masking is the new normal. In that way, I see my doctors who once they've gotten used to, most of them are actually using it on their own. So when we got an institutional subscription, they tend to use it more often and in between patients, or they also have login from their houses. So they sometimes bookmark topics and then read it later from the iPad. And the feedback that I've been getting has been very positive. And probably the best way to see if someone is using something is to pull the plug on it. And when if our internet connection does go down, they lose access to the CDSS, and then immediately, I get complaints saying that we're not able to look up this or see that. So that actually shows that people are using it. So I would say definitely within my institution, use of CDSS is new normal. We use UpToDate. We also have a subscription to Clinical Key for those who are not aware, which gives you access to journals and textbooks from Elsevier Group. But compared to that, the usage, I would say, is multiple times more on UpToDate, just because it's easy to use and you get just the information that you need, rather than having to comb through a lot of information and summarize it. So that's been our experience.
And what is the level of adoption and awareness of CDSS in non-metros among clinicians and hospitals?
In the non-metros, what I see is, sorry.
Level of adoption and awareness.
Okay, in the non-metros, what I see is a lot of individual practitioners subscribe it to themselves, and anyone who's a little forward-thinking is definitely using it. So, like I said, may not be at the institution level, but at the individual level, even if they're working in an institution, because they want to make sure that what they're treating or doing is correct, they subscribe to it by themselves.
I think there are a few more questions from the public.
Okay, I see quite a few questions in the Q&A section. Okay. I think you just read Nia's questions.
So, Nia Alexander asking, what are some of the clinical challenges across hospitals or clinics in smaller?
Okay. I would say our patients. Sometimes the patients, because patients demand some kind of treatment. They want to know, it's like, even if you're a GP, the patient comes and says, I want an injection straight away, without even, the patient thinks he knows best, he or she knows best. Like that, even if you're in a specialty or super specialty, the headache, they immediately want to see a neurosurgeon, neurologist, and they might demand certain treatments, which using a CDSS, you know that the treatment is not correct. It's like chloroquine during COVID. And of course, at that time, we were grasping at straws, and everyone started using chloroquine. But I would say that's the best example of evidence-based medicine, where they took time. In a pandemic, we're all in a hurry, so we really don't have time to do studies. But now we've been in this mode for 18 months now, so they did several studies and empirically prove that chloroquine does not have any benefit. And today, if someone is giving you chloroquine, then they're quack. Simple. So like that, the challenges can be patients still asking for certain treatments and trying to convincing them, saying that no, chloroquine is not needed, or ivermectin, there's a limited dose, limited role in that. So that is the challenge in the smaller cities.
And as an administrator to administrator, I'll ask you one basic question.
Sure.
Why should hospitals invest in CDSS? Like, what advantages will it bring to us from administrator point of view?
Okay, as an administrator, that's a good question. Like I said initially, I keep repeating this, improved outcomes, but then it's difficult for an administrator to measure this. So I'll say something that administrators can understand. And I'd say about medical legal cases, because tomorrow, as a hospital, all of us have this constant threat of being sued for something, even if you do everything correctly. And when you go to court, you've got to prove that what you did is correct. Now, if you can say that I followed this standard and you use the CDSS to have the latest information, and even when discussing with your lawyer, the lawyer immediately asks for evidence. And using a CDSS, you can print out the evidence and show them this is the standard and this is what I followed. So on a hospital, you've got the carrot and the stick. The carrot is definitely improved outcomes, better utilization, and the stick is more protection from medical legal issues.
So nowadays, most of the hospitals are having electronic health records and HMIS. So when we open a system, so going to a ward, when we open a system, we'll be having a lot of alerts popping and waiting for us. So, and adding the CDSS to our existing EMR or HMIS, can there be a alert fatigue, which can be a challenging factor for the CDSS?
Definitely. I mean, once you get too many alerts, you just tend to ignore them. It's like when you install any software, you always keep this pop-up. Do you agree to this? Do you agree to that? Or even nowadays, almost every website you go to says, do you accept these cookies? And after a while, you just give up and say accept. Like that, if you have too many notifications, you're just going to ignore it. So there has to be some kind of stratification of notifications, like really important notifications or life-threatening notifications should be given priority, and the rest should be maybe color-coded or just disappear after some time. So that's something that has to be part of the design of your EMR software, saying that only important information is alerted. Unlike the West, we tend to do more with limited resources. A consultant is expected to see more number of patients than the West, where consultant probably see 5 patients at a time, 10 patients or 10 patients, or limited OP. But here we do multiples of that. So how can we get the information that is relevant and important at the right time is going to be part of your EMR design and integration with CDSS.
And we have heard a lot of good things about your hospital regarding IT adoption and CDSS. So can you share some of your thoughts on that?
Okay. So IT adoption, by IT, most people think of the billing system, administrative system, which I think almost every hospital nowadays has. But when you're talking about how does it clinically benefit, EMRs are the way to go. So the challenge in EMR is electronic medical records. The challenge with electronic medical records is getting the data in, how to get the patient information inside, because you go to any doctor and almost uniformly they say that I can scribble something much more faster than I can type it in. And with EMR, the challenge is how to get the data, not just from the consultant, but from the ward, from the nurses. But a properly designed system with templates and integration with systems that bring in data, it is possible. Now, once you've done this EMR, it makes it so much more easier to not just look up patient information, previous information, but also link it to a CDSS so that one click you can immediately jump into that topic into the CDSS and read it up without having to retype or query it, or it's something that you put away saying that let me look it up later. And then by then you get busy with something else and you don't get a chance to see it. So with the EMR integrated with CDSS, it's so much more easier to quickly jump into a topic, read it, and come back.
Mhm. There's a question from audience. Does the digital transformation post-COVID will give boost to use of CDSS in clinical practices?
I hope so, because
Yes, yes.
definitely this pandemic has shown us that, we were getting so much more information. Like, this is the AIM standard in Delhi, this is the Harvard standard, and because it was COVID and so popular, everyone was sharing this in WhatsApp groups, lay people are sharing it. But this kind of information is there for almost every disease. It's there, and it can be unlocked if you have a CDSS.
Yes, yes. Someone is asking to name few products, CDSS products.
We use UpToDate, which is from Walter Sculver, and we find it really good. I know OUP, Oxford University Press, has a CDSS. These are the two I can think of in mind that are available.
Is this technology new to India? I can say yes, not yes, but it is being recently commissioned.
Let me probably earlier you would have to subscribe through an international website and pay a lot more, whereas now they've come into the Indian market with local representatives, people. So it's not just buying into the technology, but paying for it, but you need someone to handhold you and train people, doctors, and that way there's been more focus from the companies on India as the next growth market. So the pricing, I believe, has been tuned for the Indian market. And they also help with adoption, as in holding seminars for the doctors and being able to answer any queries. And they also have someone called engagement manager to see how much uptake is there, because they want people to use it, obviously, so that they renew it every year.
So are these vendors conducting any training camps to these nursing staff and the technical staff on the CDSS?
Yes, they've been conducting training programs for mostly our, I would say, doctors and postgraduate trainees. But at the next step, we want to have our nurses also start using it. So that's one of the other things with the campus wide kind of institutional subscription is nurses also have access to it. Otherwise, they're not going to be able to afford it. And now it's there at the ward level, and hopefully nurses or head nurses start looking up. And because we're moving to the territory wherein we have nurse practitioners, we already have anesthesia technicians, OT technicians, ICU technicians. The next step is going to be nurse practitioners who are elevated one step above nurses, but one step below in between doctors and nurses. This is common in the West. And these nurse practitioners actually have rights to prescribe certain medications. So getting information to them can only help with treatment.
So coming to this challenges point, are there any challenges beyond these finances at these non-metro cities, because they do still follow this paper system in their hospitals?
I would say, first of all, the newer generation of doctors, anyone who's graduated in the last 10 years, is the mobile generation, mobile first generation. So they are used to having technology. They don't fear technology as much as you would say the previous generation was. So they're quite comfortable using a laptop or using computer or mobile phone. It's just that the technology should be easy enough to use for them. It shouldn't require jumping through too many steps or repeating the data 2 times, 3 times. But you'd be surprised because in our hospital, we've got a few senior consultants who've been there from the beginning. And I find the senior most consultants the most enthusiastic about it. And of course, the newer consultants are readily available. And it's the middle thing, well, they're all getting on board because it's all about, frankly, how easy can you make it for them? I keep stressing on that point because I've seen a lot of EMRs, I've gone through a lot of them. And every conference you attend, someone's got EMR. And the moment you say you've got to spend 5 minutes or 10 minutes on a patient, you've lost the doctor. They're not going to do it. So how simple is it? Maybe you're lucky to have an assistant, but not everyone has an assistant to do the information. So if any good EMR should have a system with templates. So you're a pulmonologist and a patient comes in with, say, cough, and you diagnose as asthmatic. So you should be able to have a single, like 2-3 clicks, have in the asthma history filled in, just changing whatever is relevant. and then take also investigations as a single click saying this is the standard of investigation. You shouldn't have to keep typing in investigation each time. Followed by that would be prescriptions also. So if you can make it easy, yes, they have to spend some time optimizing the system and adding all their common diseases or common patients that they see. But once it's done, it's quite easy to use. The good systems are quite easy to use.
Totally agree on that. Totally agree on that. So because I always encourage my team to go for electronic records so that we can retrieve a lot of information for the medical research purpose. And yes. So do you see this CDSS can bring a behavioral change for increasing the clinical outcomes?
Yes, definitely. Because more and more, I mean, in preparation for this talk, I was talking to a couple of my consultants, more deep dive rather than usual, asking like, please give me some examples on how you use it. And they all uniformly said, we compared to when we started using it, we're using it much more than we expected. And it's not only within their specialty. Now, there's another important point I'd actually like to highlight. For example, sometimes you get a patient that is referred to you by another consultant. And now, when you become a specialist, super specialist, you're siloed into your specialty. And you may not know what's the latest in the other department. You're a pediatrician and a cardiologist has sent you a baby, sorry, the other way around. A pediatrician refers you to a cardiologist for some heart problem. And he wants to check, like, why is this medication being given by the pediatrician? They can immediately look up across specialties. One example given to me by my neonatologist was, I got a call from a gynecologist saying that there's this baby, pregnant woman with fetal hydronephrosis. And he said, my normal remedy is after the baby is handed to me. But I was able to quickly log in and say, fetal hydronephrosis and see what are the treatment modalities and help guide her also. So that way, adoption has been really great. And when you say the new normal, after a period of time, that becomes normal, it's no longer new. And I think it's normalized in our institution. And a lot of my consultants, before we went into the subscription, were individually paying for it. So it's not that it was new to them.
Yeah. That's it from my end. Thank you, Dr. Suresh, for such an informative session. It was really happy to interact with you.
Thank you.
Do we have any questions from the public? I don't think there are any. So now I'm thinking to have the CDSS in our system as well. I'll give a call to Pinky post this session.
You can ask them for a demo, 1 month demo, and enable it so that people can start using it.
We'll be happy to experience it. We'll be happy to experience a demo on that. Thank you, Voice of Healthcare, for giving us this opportunity to have a brief on CDSS. Thank you all. Thank you all for attending this session.
Thank you, everyone, and nice questions. And take care, everyone.